So today we're going to talk a little bit about mammogram screening and what gaps there are in our screening protocols. So we all know now that there's an FDA mandate that women are being sent letters and they're being told that they have dense breasts. And that puts us as OBGYNs and primary care docs in a pretty bad place. There are no standard guidelines for what we're supposed to do about this. There's a lot of advocacy out there. Our patients are frightened. And so what do we tell the patient? And I think, first of all, the letters and the advocacy has lumped together heterogeneously dense breasts and extremely dense breasts. And I think those are two different patient populations. So we know that extremely dense breasts will hide clinically meaningful cancers. They're not visible on mammogram. Mammogram is not an ideal screening tool for those patients. So what are we as primary care docs, as people ordering the mammogram, supposed to say to a patient? So what I would say for a patient with heterogeneously dense breasts is, mammogram is imperfect and you should listen to your body. And if you're noticing something that's different, pay attention and get some provider to pay attention to you. Be the squeaky wheel. You know when your body's different. For women who have extremely dense breasts, I'm a little more concerned for two reasons. One, we know that the mammogram isn't all that helpful. And number two, we know that breast density is a risk factor for cancer. So these women are at higher risk just because of their breast density. And that makes sense. They have more tissue that is at risk to become cancerous. So what do we do with those patients? ACOG would say nothing in addition. Other guidelines would say proceed to ultrasound or even MRI. The problem with ultrasound and MRI, ultrasound doesn't pick up that much more really than mammogram does, and there's a huge cost of additional biopsies and callbacks, so the risk-benefit ratio there isn't very promising. For MRI, there's incredibly great sensitivity, but the callback rate is even higher. And so the false positive rate is huge. And then the cost. And the cost of MRI is not just the imaging itself, it's also the anxiety, and it's the contrast agent. So most of us in OBGYN don't even think about, we order it with contrast because that's what the radiologist says to do. And without contrast, it doesn't really help us identify lesions. But the gadolinium that's used as contrast accumulates in the body. I did not know that until I did a kind of deep dive, but it's a little bit worrisome. We're doing these sequential MRIs in people year after year after year, and the body does not rid itself of this heavy metal. And so it accumulates in tissues in the body. That's a long-term risk that we don't really understand very well. And so what's the trade-off there? And I think for us right now, counseling a patient, we have to talk about, first of all, what's her level of anxiety? Is she really worried about this, or is she okay with just doing another screen in a year? Because many of these cancers are indolent. They're going to grow slowly, or they may even be in situ, and maybe we shouldn't be calling that cancer at all. We're never going to screen for the highly aggressive fulminant cancers. So if we can talk to a patient about the fact that doing sequential screening may be helpful, and hopefully someday, my hope is that we'll have additional tools in our toolbox. We'll have things that can help us understand the biology. We have PSA for prostate. We don't have any equivalent in breast. But what I really want to know as a clinician is this something that's biologically active, that the body is actively fighting against, that says to me this needs identification and treatment? Or is it something that's just sitting there and isn't anything? So my hope for the future, and maybe the future is pretty close to now, is that we will have tests available that we can use as adjuncts to the mammogram that will help us direct patients for those who really do need the additional imaging, and for those where we can say, gosh, the negative predictive value is so high here, I can reassure you that there's no cancer hiding in your dense breasts. So our patients are now getting these letters from the radiologists, and it describes for them that they have dense breasts. And unfortunately, the mandate didn't require them to distinguish heterogeneously dense breasts from extremely dense breasts. So the first thing I do with my patients is try to help them understand the distinction. Like half of us have heterogeneously dense breasts. That's not pathologic, that's not a problem. It's describing that your breast has gland tissue in it. Amen, that's a good thing. For the small percentage, it's 7 to 8% that have extremely dense breasts, I do try to tell them that mammogram is less sensitive and help them decide for themselves where they want to go with that. Do they want to do additional testing? And I talk about the harms and the benefits. So the harms are the additional things, whether it's ultrasound or MRI, is far more sensitive, but the cost for that is they're likely to have more positives and need biopsies and callbacks and all those things without much more identification of real cancer. And so we talk about, different people have different levels of anxiety, and some want to do everything possible and others are pretty chill. And so the idea is learn about your patient, know what your patient needs, offer her choices, but also share with her that she may be at risk for the cost of the additional things. So many insurance companies don't cover that additional. It's not really even screening at that point, it becomes diagnostic. So we have to tell them there's a cost, potentially not only in your time and potentially biopsies and false positives and anxiety, but also in dollars. So breast cancer screening is not ideal. It is not ideal to use imaging to try to understand the biology of something that's going on. Unfortunately, mammography is the best that we have. It's what we have right now, but it has some significant limitations. We're looking to see in black and white the behavior of something that we are trying to understand. So mammography in and of itself is not highly sensitive, especially in people with dense breasts, but it's the best screening tool we have and it's guideline driven. The question is, what do we do with people for whom mammography is really bad? And those are the patients who have extremely dense breasts. And the additional screening tools that we have are not great. They're still imaging tools currently. So ultrasound, which is what most of us order, will pick up 1 or 2 additional cancers per 1,000 people screened, but it also has a lot of false positives and drives a lot of biopsies and a lot of cost. MRI, much more sensitive, but also far less specific. So even more false positives. And with MRI, we have the risk of accumulation of the contrast agent. So gadolinium is a heavy metal. The body does not get rid of it, does not process it, it accumulates. And it's not something we as OBGYNs or primary care docs think about. But if we're using MRI annually in patients with dense breasts, we've got the risk of accumulated gadolinium in the kidneys, in the brain, and other organ systems in the body. So those trade-offs are real, they're expensive, and they're things we should be thinking about because our ultimate goal is care of the whole patient. It's not just finding a breast cancer. So in my mind, actually for decades, I've been thinking about what could we do better in breast cancer screening? Like, why are we still anchored on imaging, which just biologically, physiologically doesn't make any sense to me. What makes sense to me is the analogy to prostate cancer. We've got PSA, and we identify then biologically something's happening that then drives the imaging. So with current technology, with omics, genomics, proteomics, we've got lots of tools now and opportunities with machine learning and all the processing that we can do to identify signals in the blood that would tell us biologically what's happening. And my hope is that as those become mature, that we'll have an opportunity to do far better for women than we're doing currently. That we'll have an opportunity to use the biology of what's happening in her breast to then screen her and drive her, those people who do look like they have higher risk, biologically to additional screening. In an ideal world, we would have additional screening that would signal the biology of what's going on so that we could identify those patients for whom those additional highly sensitive but not so specific tests would be the best, where we would have a much higher yield in a certain patient population. Right now, all we have is if the mammogram is negative and she's got dense breasts, we move on to those other things potentially, but the yield is so low. What we ideally have is an opportunity to improve that yield by using proteomics, genomics, some blood values that would guide us to who are the right patients who need additional screening. To learn more, visit certitudetest.com.